Good morning, everyone. Welcome to Indian Static Gastroenterology Masterclass series. This is a series starting today on GI radiology. As you remember, in 2020, we had a masterclass on most of the important topics on gastroenterology and hepatology. In 2021, we had a series of 20 bedsides on important clinical case discussions. In 2022, we started with a masterclass on GI pathology and then now GI radiology. We appreciated that it is important to know about pathology and radiology, which are part and parcel of gastroenterology and hepatology practice. And therefore, we focused a specific masterclass on GI pathology and GI radiology, which are not often discussed theoretically in our clinical practice. So we're starting today on GI radiology masterclass. And among the first, we are going to have a 4 masterclass on GI radiology, talking about liver lesions or liver imaging, then imaging of small and large intestine. Then we'll talk about imaging of pancreaticobiliary system. And lastly, GI radiology intervention, different types and different varieties, and the indication and contraindication in next 4 masterclasses. In that series, we have the first of that, which is on imaging of liver, which we know is very, very important. Which test to choose, how to interpret, and what are the limitations while seeing a lesion, and how to interpret those lesions and make your clinical decision based upon those. And for liver imaging, we have a wonderful speaker today. I think I'll say the great teacher and my dear colleague, Dr. Shivanand from AIIMS, New Delhi. He's a very dear colleague, and his work is remarkable. Basically, he is a GI intervention radiologist and has a lot of work, published work in GI radiology. And to moderate this session is again my dear colleague from my own department, Dr. Salimar, very dear colleague, a dear friend. And we know he's a top-class hepatologist in our country, very well recognized both inside and also internationally. His work on various aspects of liver disease is remarkable. So I will hand over this to both of them, both of Dr. Shivanand and Dr. Salimar, to take you through the liver imaging. But before I hand over to them, I request all of you to put your questions in the chat box, and we'll try to address as many questions as possible. Please realize that the GI radiology is a very important part of our clinical practice. What imaging to choose, and therefore we designed these 4 master classes. Over to Dr. Salimar and then Dr. Shivanand.
Thank you, sir. At the outset, I'd like to welcome everyone to this ISG Masterclass on liver imaging, which starts today, which is a series of 4 lectures. So without much ado, I'd like to invite Professor Shivanand. I'd like to remind everyone, please put your questions on the chat box. The purpose of this masterclass is to answer as many queries, and whatever questions you have, whatever things you think could be, you think you have some kind of confusion, you want to clarify your doubts, put them on the chat box. So we'll have a break in between. So we'll, at the first half of the session, we'll have some questions, and at the end of the talk, we'll have the remaining questions. So please keep adding your questions to the chat box. So I invite Professor Shivanand to start with this talk.
Good morning, all. Thank you, Dr. Sharma and Dr. Govinda, for giving me this opportunity. I will, without wasting your time, I will start my slides. Okay. Dr. Shalima, hope you are able to see this.
Yes, we can see your slides. Please go ahead.
Okay. So the topic is very, very vast, and I will try to cover as much as possible without making any confusion. So this is my content. We'll start with modalities and briefly cover upon the segmental anatomy and the anatomy of the artery and the venous system. And then we will see how to approach a focal lesion and response to treatment assessment, especially in case of HCC. If time permits, I will cover the diffuse liver disease or vascular disorders. So starting with the ultrasound, now it is considered as a part of your extended clinical examination because of its easily availability, and you can do it yourself also. And it plays an important role in the assessment of liver parenchyma and detection of lesions. And whether, if at all you see any lesion, it helps to characterize whether it is a solid or a cystic in nature, which further guides you to which modality has to be chosen for further evaluation. And along with the Doppler, it helps to check the patency of the splenoportal. I'm briefly covering mainly relevant to the liver. Don't get confused as a GI imaging, and I'm mainly focusing on the liver part. In liver, along with the Doppler, this ultrasound helps to identify the patency of splenoportal axis and its complications. And in high-risk individuals, obviously, it is very cost-effective surveillance modality to pick up a focal lesion, and also it helps to guide the biopsy or a FNAC. But nothing comes without limitations. It has a main important limitation is the operator dependence, the technical limitations, but it will not help you to grade the severity of the steatosis. So if at all you want to grade the steatosis grading, then we have a better modality, that is the MRI. And the ultrasound as such, it is used as a screening modality. Mainly whenever you have a focal lesion or a patient has come for the evaluation of any non-specific right upper quadrant pain, you pick up a lesion and you have to characterize, and ultrasound is the best modality. It will characterize mainly into solid and cystic. This is the anechoic lesion with imperceptible wall, not showing any vascularity. The vessels are displaced. The characteristic feature of a simple cyst. No further imaging is needed. Just the diagnosis is very, very certain. On the contrary, it helps to differentiate whether it is a simple or a complex. I will go into the differentials of these subsequently, but it mainly helps to differentiate whether simple or a complex, and also cystic versus solid. The solid lesions may be echogenic, hypoechoic, and ultrasound is a very, very important modality in an emergency setup, especially in a patient with a fever, high-grade fever, right upper quadrant pain. So the imaging features of liver abscess is very, very characteristic. If it is already evolved into a characteristic abscess, it will show a cystic lesion with coarse, internally coarse, and the irregular inner wall and the incomplete septate. I will show these cases in a broader perspective, but just remember that ultrasound is the initial modality, helps to differentiate into solid and cystic, and any solid lesion in the liver further needs to be evaluated by multiphasic CT or MR, depending upon your availability. I will talk about which is better, whether CT or MR subsequently, but any solid lesion needs further evaluation. Whereas the cystic lesions further needs to be characterized. The ultrasound plays a role, whether it is a solid or a simple or a complex. Again, the complex cystic lesions further needs to be evaluated by multiphasic MR and the CT or a CT. This is the broad approach when you look at a focal lesion. And as I said, it helps along with the color Doppler, it helps to look at the patency of the splenoportal axis. And in case of a portal age hypertension, it helps to evaluate what is the level of obstruction, possibly cause of obstruction, like whether it is a EHPVO, NCPF, or a hepatic vein outflow obstruction. It gives a overall better information regarding the level of obstruction. And in case of any focal lesion, whether the tumor is hypervascular or containing vascularity or not, you put just a color box, it will tell you if the lesion is picking up the color or not. That will guide you whether lesion is hypovascular or hypervascular. And sometimes you see a lesion in a traumatic setup or after the intervention, patient presented with a hemophilia or aphasia bleed. you screen the liver and you see a lesion, cystic lesion, and you put a color blocks, if it takes up the color, as in this case, so certainly you are dealing with a pseudoaneurysm. Obviously, it needs further evaluation, but ultrasound, it also helps to pick up the vascular lesions also. And in liver, there are many vascular interventions we do for revascularization of the like tapes, hepatic vein stenting, or IVC stenting. Obviously, after the intervention, we need to follow these patients where color Doppler plays an important role. So it is an important modality to keep this patient under surveillance and check the patency of whatever the intervention you have done. So this is just images showing the patent. When we look at the liver, we look at the hepatic vein patient evaluation for the portal hypertension. We look at the hepatic vein, we look at the IVC, the patency of the main portal vein, splenic vein, SMV, and the left renal vein. So, and apart from the liver, spleen, and the presence or absence of ascites. So this is the role of the color Doppler.
Siva, sorry, can you put your slightly, I want to see part of your body also, slightly, put your skin, yes, perfect, yes.
This is fine, sir?
Okay. Fantastic, yeah.
Okay. Sorry. Then other important role of the Doppler is it helps to pick up the collaterals. Depending upon the location of the collateral, it helps to identify the cause of obstruction. Suppose if you see a lot of intrahepatic collateral, it's a very, very typical feature of a HOTO. You don't see a intrahepatic collateral in each EHPV or NCPF. If you see an intrahepatic or comma-shaped collaterals, it is very typical of a HOTO. On the contrary, if you see a lot of collaterals at the porta where the main portal vein is replaced, then it is very, very suggestive of a EHPO, extrahepatic portal vein obstruction. And also you can pick up a collateral that are on the gallbladder and around the spleen, what we call it as a linorenal collaterals, or in the mesentery. So all these, especially when the Doppler helps to pick up the patency and the presence or absence of collaterals, what is the location of the collateral, which will help you to identify guide you the cause, what is the cause or the level of obstruction. With the development of a contrast and ultrasound, now the diagnostic performance of the ultrasound has increased, especially in evaluation of the focal lesion in patients with a deranged renal parameters, where you cannot subject them to CT, although we have a renal safe contrast agents, especially the MR ones. But contrast enhanced ultrasound has taken up, and it has a niche indication, especially in the deranged renal parameters. This was a case. So plain MR showed a lesion in the segment 4, which was T2 hyperintense. So at that time, we did not have the renal safe agents, MR contrast agent. We used a contrast enhanced ultrasound that shows to use a contrast enhanced ultrasound, you need to have a dedicated ultrasound machine. You cannot use this contrast enhanced ultrasound with the existing ultrasound machines. Okay. So when we give this contrast enhanced ultrasound is nothing but a microbubble contained in the phospholipid shell. Once we inject into the body and we press a button, these microbubbles are broken, and they will cause, wherever there is the vascularity, this lesion has taken up these microbubbles. So lesion is hypervascular. In the next phase, portovenous phase, it is showing a washout. So in a patient with a high risk individuals, we're showing an enhancement and it's a washout. It is very, very suggestive of a HCC. But one of the drawbacks is that if there are multiple lesions scattered, you will not be able to screen all those lesions in one go. So it has a niche indication, especially deranged renal parameter, focal lesions. You cannot do a CT, then you can do this contrast enhanced ultrasound. In India, we have availability of a SonoView. There is another liver-specific contrast enhanced ultrasound which is available, widely used in Japan, along with as a screening modality, apart from the grayscale ultrasound, what is called as a sonojoid. This is taken up by the Kupffer cells. So what they do is they give a 2 injection. One, they give an injection at the start and imaging done at 15 to 20 seconds where they screen the entire liver. So if there is any focal lesion, which looks like a hypoechoic because all the Kupffer cells take up the sonozoid, and the entire liver will be looking hyperechoic, and the lesion will look like a wide. Okay, this is a wide, and all these hypoechoic lesions further need to be evaluated by second injection. What we call it as when we give a re-injection and see that hypoechoic lesion or a signal wide is showing enhancement or not. Once it shows enhancement, and it is highly certain that you are dealing with SCC. So this is typically used in Japan. We don't have access to this currently, but we have access to Sonovi. So, and also it plays an important role in following the local ablation therapy. If you are doing ablation on the same sitting, you can see how much you have ablated. If there is any residual lesion, you can do a second ablation in the same sitting. That is another role of the contrast enhanced ultrasound in the current scenario. Now coming to the CT, currently this is the main workhorse, be it liver, pancreas, anywhere. It is main workhorse for the abdominal imaging. We have 64 slices to currently 320 slices. And we have a dual energy capability. Dual energy capability means we can acquire images in 2 kV tech. One is 80 kVp and another is at 140 kVp. I will show how it looks and what are the advantages. And the current existing scanner, we can image the entire abdomen in few seconds, 2-3 seconds, and multiple phases can be acquired. Only thing, the problem is that the radiation, and if the patient is having a deranged renal parameter, we cannot give a contrast. And in oncology setup, it helps to diagnose, characterize, assess the resectability. Once the patient have undergone any local regional therapy or a surgery, it helps to assess the response to treatment. But the main problem with MDCT is that the data set is so huge, we cannot see these images on films. We have to sit on a workstation and we do a lot of post-processing, and we look at the multiple planar reconstruction algorithms, MIP images, SST. There are various reconstruction algorithms. I will not go, that is a very complex, I will not go into detail, but each has its own advantages. It gives you the roadmap and also helps to pick up the subtle vascular lesions, especially in patients with GI bleed or any vascular complications. Whereas the dual energy technique, if you see here, the left panel is a low kV technique. It helps to pick up the very, very small satellite lesion. This was a large lesion in the segment 4. There are multiple small satellite lesions adjacent to it. So very small lesions are picked up by the low kV technique. And however, it lacks the spatial resolution. On the contrary, 140 kV technique, the subtle small lesions may be missed, but it has got a good spatial resolution. And you can generate an iodine map. The iodine map is nothing but wherever there is a, hello?
Whenever we can hear you, please go ahead. Please go ahead.
Yeah, someone is marking it. Sorry. Thank you. The role of dual energy is that apart from the picking up the smaller lesions, we can generate a virtual non-contrast images. You don't have to acquire a different set of image or subject the patient to radiation. You can retrospectively acquire a non-contrast images, especially looking for any bleed. And iodine map is nothing but wherever, obviously you are giving iodinated contrast media. So whenever there is a vascularity or any viable tumor is there, the iodine will be taken up by that lesion if it is enhancing. So for example, this patient has undergone ablation. This is the routine CCT that is showing a hyperdense area in the treated area. We are not sure whether this hyperdense area is a viable tumor or it is just a post-treatment change. So when we generated the iodine map, this hyperdense area is not showing any iodine uptake. That means it is just a post-treatment change or a hemorrhage. It is not an actually tumor. when we generated a virtual non-contrast enhanced CT, so the heterogeneous area seen on CCT, it is looking hyperdense. It is nothing but a hemorrhage, not actually tumor. So that is an important role of a iodine map, where um, which is a application of a dual energy CT. Now coming to the MRI, so it has multiple paradigm. Unlike CT, we can image them in a multiple phases, but the MR has got a multiple paradigm in the form of we have T1, T2, in phase, out phase, diffusion weighted image. So because of multiple paradigm, it is currently considered as a problem solving modality, especially in liver focal lesion evaluations. So if you ask me which is the better modality for evaluating a liver focal lesion, especially you want to do a multi-phase CT or MR, it is a MR because of, but the problem with the MRI is that availability and the long acquisition time and the breath hold. If the patients are having ascites, breath hold will be a problematic. So if these none of these problems are there, the MRI outweighs the CT, and considering the cost as an, that is a different issue. But in terms of advantage, obviously MRI plays a better role. And we have currently, earlier people used to say the one of the risk of the gadolinium is in a long-term complication was the nephrogenic systemic sclerosis. But we have now the safe agent like dotaram, which can be used even in patients with the deranged renal parameters, that one should be aware of it. If someone asks that if patient is having renal failure, we cannot use the MRI contrast, cannot give a gadolinium contrast, but you can always tell them that there is a dotaram can be used. We have like in ultrasound, we have in MR, we have a hepatocyte specific contrast agent like gadolinium Bopta that is available in India. And another one is the gadolinium EOB or gadotexic acid or Eovist. So this gadolinium EOB is not available in India, but the difference is that the Bopta has got 8 to 10% biliary excretion, whereas EOB has got 70 to 80% biliary excretion. And hence the imaging time of the gadolinium is very short, and the gadolinium Bopta we have to wait for 1 hour. And one of the problem with MR is obviously in patient with implant or pacemaker, it's a problematic. And coming to what is, if you ask whether you want to use only simple gadolinium or a hepatocyte specific agent, if you have access to hepatocyte specific MR agent, you are looking for the liver pathology, go for a hepatocyte specific contrast agent. It has both the advantage of extracellular property as well as it is taken up by the functional hepatocyte, and it helps to pick up very, very small lesions, and it has guide you. Some of the lesions are highly 100% specific that you don't need any imaging. For example, so this is a lesion, echogenic lesion in the right lobe of the liver, solid lesion. Obviously, this patient underwent a CT that shows the lesion is enhancing in the arterial phase, has become iso in the portovenous phase and not seen in the delayed phase. Obviously, you can think of either FNH or hemangioma, but it is not showing any washout. When we did a MR in the same patient, so the same lesion is showing enhancement in the arterial phase, is persisting in the portovenous phase, has become iso in the delayed phase. But if you look at 1 hour hepatobiliary phase is nothing but where all the functional hepatocyte, wherever there are functional hepatocyte, this contrast will be taken up. So if you see here, the background liver is also hyper, and the lesion is more hyper than the rest of the liver. That means this lesion contains the functioning hepatocytes. So this was nothing but FNH. We don't need any biopsy. We don't need any further imaging. Just you are certain that this is a focal nodular hyperplasia. That's it. That is the beauty of the hepatocyte specific contrast agent. If you have access, go for it. Now, whether you are using a CT or MR, you should be able to understand what are the contrast study phases. When we when you come to discuss with us, we talk about whether it is arterial phase, early arterial phase, late arterial phase, portovenous phase, delayed phase. What does it mean? And what are the advantage of each phases? In liver imaging, non-enhanced or NCCT, it helps to pick up the calcification, fat, hemorrhage. I'm talking about only the liver. Followed by what we do is the early arterial phase. Early arterial phase is nothing but the contrast is remaining only in the vascular compartment. It has not reached in the parenchyma at all. So usually it is about 15 to 20 seconds. Once you start giving inject, we acquire at 15 to 20 seconds. So where, if you see here, all this bright area, this is the contrast is remaining in the arterial tree. So what is the relevance? It helps to look at the arterial map, vascular map, especially surgeons, or you are picking up, looking at the vascular lesion like pseudoaneurysm. So this plays an important role. But this phase has a very, very poor role in characterization of the liver focal lesions. Early arterial phase, because it has not reached the parenchyma, it remains in the vascular compartment. Very useful look at the vascular mapping and also the vascular lesions, especially in GI bleed or pseudoaneurysms. Coming to the late arterial phase, usually we acquire at 35 to 40 seconds following the contrast injections, where the contrast has reached the parenchyma and little bit there is opacification of the portal vein. So this is the phase where we call it as the arterial phase for characterization of the liver focal lesions. So it helps to detect HCC, FNH, adenoma, and it is the same phase where we call it as a pancreatic phase in pancreatic tumors. Okay. And followed by, we acquire another phase, what we call it as a hepatic phase, where the contrast has reached the hepatic veins. In late arterial phase, there is a little bit opacification of the portal vein, but in the hepatic phase, the entire liver parenchyma is enhancing, and there will be opacification of the hepatic veins. Usually it is at 70 to 80 seconds from the time of contrast injection. So again, it helps to characterize the focal lesions, especially in HCC. If it is HCC, it will show washout. And it is an important phase for the metastatic workup, because most of the metastatic lesions will be better appreciated in the parenchymal phase or a hepatic phase. Now comes the delayed phase. Again, when we say it is a multiphasic, all three image phases are acquired: late arterial, portovenous, and the delayed phase. Delayed phase is acquired at about 5 to 6 minutes. Again, this plays where entire contrast has washed off from the liver parenchyma. Only the fibrotic areas, the fibrous containing lesions will be showing uptake, like the cholangiocarcinoma, fibrotic metastasis, and obviously in kidney, the contrast will start excreting. You see the lesions if there are any in the pelvic calyceal system. So in the delayed phase, very fibrotic component helps to characterize lesions in cholangiocarcinoma, like cholangiocarcinoma. So just for your summary, when you have timings, if you in the exams, if someone asks what are the timings, in late arterial phase is about 35 to 40 seconds from the start of injection. The portovenous phase or a hepatic phase, it is 70 to 80 seconds. The delayed phase is at 5 to 6 minutes. So plays a role in cholangiocarcinomas. If you are using it MR, hepatocyte specific contrast agent, what we call it as if you are obviously Primovist or Evovist is not available, we acquire at 20 minutes. If you are using a multi-hands, which is available in India, and we acquire at 1 hour. So this is relevant only for MRI, but the rest of the three phases are equal both in MR and CT. So just to show you importance, this is the early arterial phase. Although there is a lesion, you are not appreciating the enhancement here. The same lesion in the late arterial phase showing a heterogeneous enhancement, you are better appreciating the lesion. So whenever there is a focal lesion, we tend to do a late arterial phase rather than the early arterial phase. So this is just to diagrammatic representation. You have to understand when we talk of a focal lesion, always look at the two phases. One is the arterial and another is the portal venous phase. And in the arterial phase, always look at the lesion in contrast to the background liver, whether it is enhancing or not. If it is enhancing, we will call it as whether it is homogeneous, non-rim type, or it is a rim type, or a nodular type, or at all, it may not be enhancing at all. Then we call it as a non-enhancing. So this is the arterial phase. Coming to the portal venous phase, we have to look at the background liver, whether the lesion is equal to that of the background liver, we call it as iso. If it is darker than the background liver, we call it as a washout. If the same lesion was enhancing earlier, if it has become dark, we call it as a washout. Or if it is appreciated only in the portal venous phase, we call it as a hypovascular lesion or hypoattenuating lesion. And if the same lesion, if the lesion is brighter than the background liver, we call it as a hyper attenuating. Or if the lesion was earlier enhancing, but if it is retaining or if it is become more than the background liver, we call it as there is a retention of the contrast. So these terms, they are very, very relevant in characterization. For example, the HCC lesions will show enhancement in the arterial phase. In the photovenous phase, it will become less than the background liver. We call it as a washout. That is typical of HCC. On the contrary, the adenoma or a FNH, it will show enhancement in the arterial phase, but it will not be darker than the rest of the liver. It will be either more than the background liver or equal to the liver. Then either it could be adenoma or a FNH. So the adenoma or FNH, they will not be darker than the background liver. So that is how we characterize lesions depending upon the enhancement pattern of these lesions. So this is just to give a guide. In the arterial phase, you will look at the enhancement and it characterizes the enhancement, whether it is non-rim type, rim type, nodular type, or a non-enhancing. And in the portal venous phase, you will say, is there any washout or a retention? So now coming to we have looked at all the modalities, how and the phases. Now look at the segmental anatomy. This is very, very relevant since you are dealing with the focal lesions. You have to talk to the surgeon or the intervention radiologist. So you have to talk in the same term where the lesions are located. So this is the surface anatomy of the liver. You have to draw few lines, then the anatomy is very, very simple to remember. It is not complicated at all. One is you have to draw a horizontal line at the level of the portal bifurcation. So that will demarcate the liver into superior and the inferior segment. So portal bifurcation is one line, that is a horizontal. Now we have to draw 3 vertical lines. One starting at the ligamentum fissure, falciform ligament, that everyone will appreciate. So that is one vertical line. Another vertical line is drawn at the middle hepatic vein, and the third one at the right hepatic vein. So 3 vertical line and 1 horizontal line. So horizontal line is at the portal bifurcation. The vertical line is one at the falciform ligament, second is the middle hepatic vein, and the third one is the right hepatic vein. So just remember this. And now go from clockwise direction. The segment 1 is caudate lobe. So it is far posterior, just anterior to the IVC. So it is not at all difficulty to identify the caudate lobe. I will show it how it looks on the axial section. Now start from clockwise. So starting from above the portal bifurcation to the right of the falciform ligament, it is the segment 2. The same segment below the portal bifurcation to the right of the falciform ligament. So it is the segment 3. When you go further to the right, that segment becomes 4B. Superiorly, it becomes segment 4A. When you go from, this is the middle hepatic vein. The middle hepatic vein separates the right lobe from the left lobe, that is segment 4. When you go further on the right side, the below the portal bifurcation, we have segment 5 and 6, and the same segments above the portal bifurcation, it becomes segment 7 and the segment 8. So that's it. So I will show it how it, although it is seen on the surface, how it looks on the cross section. So this is the representative diagrammatic representation of the CT section or the liver or MRI section. So we are looking at the superior segment above the portal bifurcation. So it is segment, if you see here, this is the yellow line, the section taken above the level of portal bifurcation. So if this is the line which is going across the falciform ligament. So this is segment 2. This is the IVC. This is the middle hepatic vein. This is the right hepatic vein. This is the caudate lobe. The section between the middle hepatic vein separates from segment 8 and the segment 4. So this is segment 4 in the superior part above the portal bifurcation, or what we can call it as the area between the falciform ligament separates the segment 2 and 4, and the middle hepatic vein separates segment 8 and the segment 4. Okay, and on the right side, the right hepatic vein separates the segment 7 and the segment 8. So superiorly, we have segment 2, 4, 8, and 7. The same segments, when you come below the level of portal bifurcation, it becomes segment 3, segment 4B, segment 5, and segment 6. And this is almost at the level of splenic vein or a splenoportal conference. So above it is 2, 4, 8, and 7. Below the bifurcation is 3, 4B, 5, and 7, 6. So when I apply it on the CT sections, the blue line is the falciform ligament, the red line is the middle hepatic vein, the green line is the right hepatic vein. So above the portal bifurcation is segment 2, 4, 8, and 7. Below the portal bifurcation, it is segment 3, 4B, 5, and the 6. And the caudate lobe is standard. It is anterior to the portal vein. So it has its separate system altogether. It won't be difficult to appreciate the segment 1. Just anatomy, if you going to the anatomy part, the caudate lobe is located anterior to the IVC and posterior to the main portal vein. The relevance of caudate lobe is that it has separate, it takes a blood supply from both right and left hepatic artery, and it has a independent venous drainage that it will drain directly to the IVC. So because of its peculiar anatomy and vascular architecture, it is relatively spared in most of the diseases, especially in cirrhotics. You will see a hypertrophy of the caudate lobe, and also in Budd-Chiari syndrome. Okay, so and it is called as a segment 1. Obviously, when you deal with a surgeon, you have to understand whether this particular patient with a focal lesion is undergoing what kind of a resection. So when we call it as a right hepatectomy, it includes all the segments of right lobe, that is 5, 6, 7, and 8. If surgeon says that we have to do a extended right hepatectomy, you are going to include segment 4 in addition to the entire right lobe. Whereas left hepatectomy means segment 2, 3, and 4. Okay, that is the left hepatectomy. When you call it as an extended left hepatectomy, it includes 5 and 8 in addition to 2 and 3 and 4. Okay, So these are the various nomenclature. You should be aware of it because the surgeon will talk in terms of these segmentectomy or right hepatectomy, extended right hepatectomy. So coming to the arterial anatomy. So in the body, the hepatic artery is one of the has got a significant variations. I will not go into each variation, but remember that it has a lot of variations. So the typically, if you get an angiogram, how to interpret it? This is a celiac axis, which trifurcates into three branches: splenic artery, left gastric artery, and the common hepatic artery. The common hepatic artery divides into gastroduodenal and the hepatic artery proper, and the hepatic artery proper divides into right and left. Okay, and the right hepatic artery further divides into anterior and posterior division. So this is the standard branching pattern of the celiac axis or the hepatic artery. And one of the commonest variation of the hepatic is that replace right hepatic artery arising from the SMA. So in exams, in DM exams, you may be put a CT and ask what is this artery. So normally the hepatic artery, the standard hepatic artery goes anterior to the portal vein. This is the portal vein. And if you see any vessel going posterior to the main portal vein, so you should be able to tell that it is a replaced right hepatic artery. Okay. So this is the angiogram of the same patient. If you see here, this is the right hepatic artery arising from the SMA, and it is going posterior to the main portal vein. Like the hepatic artery, the liver has got the venous system, two venous system. One is the portal and another is the hepatic venous system. How the portal system is formed? We have splenic vein, IMV, and the SME. These are the tributaries. They form a confluence behind the neck of the portal vein, pancreas. And this will form a main portal vein which ascends and bifurcates into the right and left portal veins. And the main portal vein on Doppler, it has a typical hepatofetal continuous, the undulation above and the basic, below the baseline is very, very characteristic of a portal circulation. What we call it as it is due to the respiratory variation. In case of portal hypertension, this variation will be lost and the flow will come again below the baseline. We call it as a hepatofugal, or if it is above the baseline, it is a hepatopetal. Normally it is hepatopetal and a continuous undulation is a typical. In case of cirrhosis, this undulation will be lost. Like hepatic artery, the portal vein has got a lot of variation. It is a very, very relevant if your patient is undergoing for the hepatic surgery or a portal vein embolization. Otherwise, it is just academic interest. I will not go into further detail. Now coming to the venous system, hepatic venous system, we have three hepatic veins. The right hepatic vein drains separately into the IVC, whereas middle and the left, they form a common complex in 96 to 97% of the patient, and it will drain into the IVC. So we have right and middle and left together form a complex and drains into the IVC. And this is a CT and MR representation, right hepatic vein, the middle and the left joining and draining into the IVC. Unlike the portal vein, this hepatic vein has got a triphasic waveform because all the cardiac pulsations are transmitted to the hepatic veins. You will see a triphasic waveform, which is very, very typical of a normal hepatic vein spectral waveform. In case of HVTO or Budd-Chiari syndrome, this waveform will be lost. It will become monophasic. So you should be aware of what kind of waveform you see in hepatic. Hepatic veins, we will have a triphasic waveform, whereas portal vein, we have the continuous undulating hepatofetal flow. Okay. Like portal system and the hepatic artery, the hepatic veins may be variations like apart from right, middle, and left, we have superior, middle, and inferior accessory hepatic veins. Again, it has a relevance in the surgical point of view. And it is only academic interest. But sometimes in HOTO, right hepatic vein may be completely occluded, but impaired right hepatic vein may be present. So you just have to open the IVC so that entire liver gets drained to the impaired hepatic veins. So it has a intervention point of view, surgical point of view. These are the accessory hepatic veins are very, very relevant. Just remember that the liver has got a lot of variation in the arterial system, portal venous system, as well as in the hepatic venous system. Just to complete the anatomy. So suppose if you see a air, this is very, very on CT, you should be able to differentiate whether this gas, whether this air is present in the portal system or in the biliary system. So if you see a air going up to the surface and lot of ramification, you are certain that this gas is present in the portal vein. On the contrary, where if the air is present in the biliary system, it won't reach the surface. It will be centered in the middle of the liver. It has only few branching pattern. So pneumobiliae will be localized in the center, whereas the air in the portal system, it will reaches the surface. So you should be able to differentiate whether it is a pneumobilia or a gas in the portal vein. Dr. Shalimar, this is the first part. If you have any questions in the system, we can have regarding this part.
Okay, I think we had an excellent presentation from your side, highlighting the basic utility of investigative modalities, which every gastroenterologist or hepatologist need to know, right from ultrasound, CT, MR. And I think we've got couple of questions in the chat box. Dr. Kesri Singh wants to know what is the criteria for saying hepatomegaly or splenomegaly on an ultrasound?
Roughly, there are a lot of variation, but roughly during ultrasound, we look at whether the liver margin is reaching beyond the kidney margin. Then we take it as a hepatomegaly. And similarly, spleen, we take it as more than 15 centimeter in craniocaudal as a splenomegaly for this splenomegaly. But hepatomegaly, we roughly don't measure in the craniocaudal direction, but if it reaches the inferior pole of the kidney, then we make a diagnosis of a hepatomegaly.
Siva, slightly, if you can, screen down slightly or more face and hand movement. Yeah, yes.
Okay, sir?
Slightly more. Yeah. We are missing your hand movements. Yes.
Okay,
the hand gesture.
Okay.
Yeah.
Just carrying forward the same question, Dr. Kondal Rao wants to know what is the normal portal vein diameter and velocity?
Yeah, normal portal vein diameter, velocity I have already said it is 20 to 40 centimeter per second, and the diameter, we take it as upper limit up to 13. More than 13 mm is taken is abnormal. And but in case of portal hypertension, the diameter, if there is any spontaneous shunt or the blood is draining through a large shunt like recanalized parambolical vein or a linear shunt, this portal vein, even though patient is having a portal hypertension, the diameter may be very small. And so it is very, very non-specific criteria to make a diagnosis of a portal hypertension, what I can call. So the cutoff point is 13 mm. More than 13 mm is abnormal.
Okay.
And the velocity is 20 to 40 centimeter per second.
Right. Okay. So Piyush Mishra wants to know the criteria used for grading fatty liver on ultrasound.
Yeah, there are 3 grades. One is the increased echogenicity means is echogenicity more than the renal cortex, but the portal radicals, the diaphragmatic surfaces are well seen in grade 1. In grade 2, what happens is the anterior echogenicity of the portal vein, the portal vein becomes imperceptible, but the diaphragmatic surface is well seen. In grade 3, the portal vein outline as well as the diaphragmatic surface become imperceptible. So it becomes more echogenic. All these structures will not be appreciated. So these are the grading of the fatty liver on ultrasound.
So Dr. Sai Prasad has raised a question that on how can you differentiate an HCC from a regenerating nodule in a case of Budd-Chiari syndrome?
Yeah, I have a detailed presentation now. When I talk about the focal lesions, I will talk about it. I have a slides. I will show it.
I think the other questions are the liver segments using ultrasound, which you have shown very beautifully in the slide. So we'll skip that question, and then
Yeah.
next question is from I don't know the name of the person, but how on ultrasound can you differentiate bile ducts from vascular structures other than Doppler? Is it possible?
Yeah, normally the non-dilated biliary systems, they are very less than 2 mm. They are usually not appreciable. So once they are dilated more than 2 mm, what we do is that we put a color. So bile ducts do not take up the color filling, and whereas the portal vein or a hepatic artery, they fill in. So that is how, and also the bile ducts don't have a echogenic wall, whereas the vascular structures, they have a echogenic walls.
Okay. Next question is from Iris. So the question is, what is the best diagnostic modality for an SOL liver evaluation in a CKD patient who's not on dialysis, or say who's on dialysis? How would you approach in terms of the imaging modality?
Obviously, if the patient is on dialysis and the urine output is 0, you can go for the CT. It does not have any relevance. But the patient is on having the urine output, and there is a residual parenchyma is functioning, renal parenchyma is left. Then rather than going for a CT, you go for a MR, or if you have access to CUS, if it is a single lesion, again you can go for a CUS. And if at all you want to have a because the CUS, one of the problem is that it won't be well appreciated or interpreted by the surgeons, because it's only a person who is doing that, he can appreciate that, because it's real-time imaging is very important in CUS. But if you want to go and talk to the surgeon, he needs a resection, you need to have a very objective imaging, that then you go for a MRI triple phase with using a DOTARM. So the DOTARM has currently, it's recommended by all the association in patients with CKD, whether he or on dialysis present or not. So it's the risk of nephrogenic systemic sclerosis is very rare in that.
Right. So Dr. Vijay Shankar wants to know on ultrasound, what are the best findings to conclude that the patient has portal hypertension?
An ultrasound?
Yes.
Yeah, apart from the morphological features, in early changes, we look at the flow pattern. So in early, I have already said that the normal undulation will be lost, and the flow will become, the velocity will become reduced, although flow will be hepatofetal. As the morphological changes starts happening, like fissural widening, the irregular surface, then the hepatofetal will become hepatofecal. That means the flow will be below the baseline, and that means the flow is away from the liver, going away from the liver. That means it is towards the spleen or the bowel, not towards the liver. So initially we take at the portal diameter, it is very non-specific, because in presence of a shunt, the portal vein diameter may be very small. Still, patient may have all the portal hypertension complications. In early stage, portal vein diameter more than 13 mm, loss of respiratory variation, hepatofugal flow. These are the color Doppler finding. The morphological features are obviously small liver, coarse ecotexture, irregular surface, varices, and the collateral presence.
And I think we've got a lot of questions, but we need to move forward. We will take the questions at the end of
Yeah,
the presentation.
some of the question I can see that I'm going to cover them actually.
Yeah,
No?
so I think we can continue with the rest of the talk, and maybe we'll come back to these questions if they have not been answered in your talk.
Yeah. Okay. So now coming to the focal lesions, how to approach. So three things you have to ask yourself when sitting in a OPD, or you have encountered a lesion. A patient is carrying a imaging with a focal lesions. So whether the patient is having underlying liver disease or a malignancy. If it is not there, most of these lesions tend to be incidental. Not always, but it helps to narrow down your differentials. If it is a underlying liver disease, the commonly you want to think of it is a solid lesion. You want to think it in the line of HCC. We have to apply a LIRAD system. I will discuss it. If it is a patient is having already a known malignancy, if you see any solid lesion, then obviously one may start thinking it could be a metastatic. This is broad how you want to approach. Now, one by one, if the patient does not have any liver disease, no underlying malignancy, ultrasound shows it is helps to narrow down further into cystic and solid. If it is a cystic, you have to classify into the simple or a complex, because simple cysts, the differentials are different. The complex cysts the differentials are very, very narrow. So how will you differentiate? So any cystic lesion which is very anechoic, homogeneous, no echoes, if at all, and it has got a smooth margin and imperceptible wall, so you are certainly dealing with a simple cyst. So the simple cyst, they tend to be very, very incidental, maybe single, multiple, and they are seen as an anechoic structure, and the wall could be very, very imperceptible. You may not be appreciate the wall, do not show any vascularity. Sometimes you may see a hemorrhage inside. And on CT or MR, they tend to be hypodense or non-contrast. On MR, they show brightly hyperintense on T2-weighted and do not show any enhancement following the contrast. So do we really go for multiphasic MR? If you are certain with a simple cyst, this kind of appearance, no. It is just a simple cyst. No further CT or MRI is needed unless it lacks these simple cyst features. Whatever I will come to the complex cyst. The as I said, it could be single or a multiple. It is just a number, but the appearance remains the same. And they may get complicated by hemorrhage following the trauma or a spontaneous. If you see here, these are two cysts. In the segment say 4, there is a hyperdense content inside, and this is a MR showing the hyperintense layering between in the cyst that is suggestive of a hemorrhagic cyst. Again, this does not need any intervention or any further. You can just keep these patients under follow-up, what is happening to the size. One of the problem with the simple cyst that it could be a hydatid cyst. There are various types of hydatid cyst. The type 1 hydatid cyst may have an appearance similar to or akin to the simple cyst. So that is one of the area where we may go wrong. Like it could be a hydatid cyst or it could be a simple cyst, especially the type 1. In such cases, the serology or a cyst aspiration fluid serology will be very, very helpful. Or if the patient is coming from an endemic area, and if you see such a large cyst and find internal echoes, sometimes usually the simple cyst does not have any internal echoes. If you see some fine internal echoes, and all the features are fitting in a simple cyst, and you can see a wall, then you can make a diagnosis of a hydatid cyst. But whereas simple cyst, you don't have a wall actually, you don't have an internal echoes. So these are the salient features. It comes with experience, and sometimes we go wrong in such cases. Hydatid serology in type 1 hydatid cyst, in 20 to 30% of the patients, the serology may be totally negative, but the aspiration from the cyst and doing a serology of that fluid, it's very um, uh, helpful. But otherwise, you can keep up this patient under follow, see whether there is a size increasing. In few days, if it is a hydatid, and you may start seeing a floating membranes. In such cases, it becomes a diagnostic. In some individual cases, it is really becomes a problematic whether we are dealing with a simple cyst or a type 1 hydatid cyst. Other cystic lesions, simple cystic lesions could be multiple cysts, could be a Caroli's disease. These are nothing but a multifocal cystic dilatation of the intrahepatic biliary radicals. And if you see any central echogenic foci, these are nothing but a Porter radicals. So we call it as a central dot sign. It is very suggestive of a Caroli's disease. And MRI, CT helps to define the, is there any extrahepatic disease? One also helps to look at the, is there any hepatolithiasis? If you see here, this is MR showing the cystic dilatation. Also, there are multiple stones or a hepatolithiasis inside this dilated cystic duct. So this appearance is very typical of a Caroli's disease. Another benign variant is the biliary hematoma. Especially this variation may pose a diagnostic problem in patients with known malignancy, because this one may mistake it for the metastatic disease. No, this appearance is very typical, especially these cysts are very fine. They are uniform size, scattered in both the lobes. They do not communicate with the biliary tree, and they do not enhance, or they do not show any rim enhancement or any washout. These are like a pure cyst, tiny cyst, and they are scattered and they are of uniform size. So once you see this kind of picture, aware of this picture, you will not go wrong. It's one of those pictures you will never forget. So this is case of a biliary hematoma. One should not be mistaken for a metastatic disease. Suppose if you are seeing a lesion in a case of post-traumatic setup, or after the intervention, patient presents with a bleed, you see a cystic structure and put a color, and it starts showing a color filling in. And you take a spectral waveform, it is showing a high velocity waveform going to and fro across the baseline. So certainly you are dealing with a pseudoaneurysm. In such cases, it should be further evaluated with a CT angiography. It will give you the vascular map and also guide you save your time if you are going for an intervention, which artery has to be tackled, rather than if you you can go after the Doppler also you can go for, but it's better to get a CT angiogram. It will give overall overview what is happening to the surrounding area. Is there any associated hematoma? Is there any multiplicity? So that set a CT, and if the patient is provided, patient is stable. Okay. So if you don't put a color Doppler, you may mistake it for just a simple cyst. Also, we always try to any cystic lesion, we always put a color to see whether is there any internal vascularity present or not. Now, so we have seen what are all the kind of simple cystic lesions we can get. So when we have a irregular border, septations, solid areas, loculations, so that cyst is no longer a simple cyst. It becomes a complex. The complex cyst always need to be evaluated by the either multiphasic CT or MRI, and the CT will suffice. If you have access to MRI, it's an advantage. It's not must if you are evaluating for a complex cyst. Okay. So what are the complex cysts you can encounter in a clinical practice? The one is the hydatid cyst. I have already talked about the simple hydatid cyst type 1. So it looks like a simple cyst. You may go wrong, but beyond that, it won't be a difficulty in classifying the hydatid cyst. There are various types. The one is the cystic locular, that is type 1 simple cyst or a cystic locular without any septation, without any internal echoes, no floating membrane. That is as good as a simple cyst. Whereas the cystic echinococcus 1, it starts showing internal echoes, and you can demonstrate a wall. And the 2, cystic echinococcus type 2 is you start seeing the internal membranes. So if you see this kind of a picture, no differential, it is highly suggestive of a hydatid cyst. Then the cystic locular, cystic echinococcus 1, cystic echinococcus 2, these are active stage. Okay, these are active one. Once you start seeing a crumpled membrane or a solid areas, this become 3A, 3B, and a 4. These are 3A, 3B or a transitional phase. Whereas type 4, the cystic echinococcus 4 and the 5, the 5 is nothing but a calcified. These are inactive. Okay. So based upon the ultrasound appearance, we can classify it into various stages. But important to remember is that the early ones, they are reactive, and the late ones, 4 and 5, are the inactive ones. And these floating membranes, the peripherally arranged daughter cyst, these are very, very classical. In these cases, serology positivity rate is also very high. The only problem comes in the simple, the type 1 hydatid cyst. Coming to when you will do CT or MR, especially in hydatid setup, especially you are suspecting a complication, either peritoneal dissemination, biliary communication, or you want to look at the multiplicity, what are the other organs are affected, then you should go for a CT or MRI. But more or less in hydatid cyst, you are able to classify these. But you have any difficulty, whether it is hydatid cyst or something else, you should go for a multiphasic MRI or a CT. So what is the common differential we can go wrong is the biliary cyst adenoma. So just remember that the biliary cyst adenoma or cyst adenocarcinoma, it also presents as a complex cystic lesions, usually seen in middle-aged females. It is usually a large cyst with multiple septations, peripherally arranged cyst. You may have solid areas and irregular septae. And these septae, unlike hydatid cyst, these septae tend to enhance. The hydatid septae, they never enhance. Just remember that. And in case of a biliary cyst adenoma, you tend to see some solid areas, and the peripherally arranged daughter cyst in hydatid, they are typically peripherally arranged, whereas in biliary cyst adenoma, these are randomly arranged. You will see a septae and sometimes calcification, and these septae will enhance. This is how you differentiate biliary cyst adenoma from a hydatid cyst. And you are evaluating a case of a hydatid cyst and you are not sure is there any difficulty in classifying it as a hydatid cyst, always go for a CT or MR multiphasic. It will help you to better characterization. So how will you differentiate biliary cyst adenoma carcinoma? The presence of thick septation, nodularity, solid area separated from the biliary cyst adenoma. So this is a case. If you see, there are two examples in the upper panel ultrasound showing a multiple septations, and there's a complex cyst, and MRI showing an enhancing septae. So this was a case of biliary cyst adenoma. In the lower one is the biliary cyst adenocarcinoma showing thick septation, solid areas, and the CT confirming that picture. These are spongy kind of appearance, multiple septae, and solid area enhancing area. So this is a very, very typical of a biliary cyst adenocarcinoma. Again, MRI, if you see here, one may call it as a hydatid cyst. No, it is not a hydatid cyst because there are enhancing septae and there are solid areas which are also enhancing. So in hydrated cyst, the sand or a septate will never enhance. Just remember that. One of the other differential for the complex cyst in emergency setup is the abscess. Usually, it won't be a difficulty in making a diagnosis of a liver abscess because it has a typical appearance. Usually, it tend to be large, solid, single lesion in the right lobe. It will show irregular on ultrasound, irregular thick, irregular inner wall, and coarse internally coarse. Or the CT and MR helps to identify the associated complication, whether it has ruptured, and also it helps to look at the what is the parenchyma is left all around, because if the parenchymal thickness is less than 5 mm, there is a high chances that it may rupture into the surrounding area. So what are the typical features of abscess on CT? So inner, you will have a low attenuation core, followed by enhancing wall, and followed by any hypointense or a hypoattenuating parenchymal edema. So what we call it as a double target sign. The double target sign is that enhancing wall followed by hypoattenuating compressed parenchyma. That is due to parenchymal edema. So this appearance is very, very typical of an abscess, and you may see an incomplete septate or an irregular wall. So when you have this type of appearance, so and a single lesion in the right lobe, you can make a diagnosis of a amoebic liver abscess. Okay. Whereas this is another example. Again, there is enhancing wall with peripheral hypointense rim because of parenchymal edema. This is a case of a liver abscess. On the contrary to amoebic liver abscess, the pyogenic tend to be multiple, small. They are scattered in both the lobes. Sometimes you may see a air fluid level. So again, the enhancement pattern remains the same. Whether it is amoebic or a pyogenic, you will have an enhancing wall and a peripheral edema, but they are scattered in both the lobes. Now comes the problem. Problem comes is the if the patient has come in early stage, it is not completely evolved into abscess. It is still in the early stage, like evolving abscess. It poses a diagnostic problem. But the clinical picture is such that the patient is in sepsis, is having a right hypochondriac pain, and the liver shows a echogenic area, ill-defined. You are not appreciating any wall or a liquefaction. Then what we advise is that go for either follow-up scan after few days, you may start seeing a liquefaction, or else you go for a CT. So CT will obviously give a better picture, or else follow-up imaging after 2 to 3 days, you can start seeing a liquefaction. So that is one of the problematic area. And another is that you may see sometimes lesions clustered only in one segment or two segments. So you in a patient with a known malignancy, you may think of whether these are abscesses or a metastatic lesion. So that may be a helpful one of few signs to differentiate whether these are abscesses, cholangular abscesses, or a metastatic disease. So how will you differentiate? The cholangular abscesses tend to be very, very clustered in few segments or one segment. And the double target sign, what I had described for the abscess, that will be present, that enhancing rim with peripheral halo and with a significant peripheral edema, and that will be limited to one segment. And it may or may not be associated with intrahepatic biliary radical dilatation. Just remember that. It's not always that these cholangular abscesses need to be associated with biliary dilatation. No. If they are clustered and the picture is just like abscess and clustered in one segment, so you are certainly dealing with cholangular abscess. On the contrary, the metastasis will show only target sign, that you will not have any halo. You will see a peripheral rim, but you will not have a halo all around it, unlike in cholangular abscesses. And you will these will not be distributed in one segment. They will be distributed randomly in both the lobes, and there will not be any parenchymal edema. This is how you will differentiate cholangular abscess from the metastatic disease. Again, if you see here, there are multiple lesions clustered in segment 6 and 7 with lot of edema. And if you see on T2-weighted image, although these lesions are very, very small, clustered in one segment and with a lot of edema all around it. So this is a typical sign of a cholangular abscess. If you remember this picture, you will not go wrong. Coming to the bilioma, you need to have a typical clinical setup. Usually they are seen after trauma or after biliary surgery or a hepatic surgery. So, or sometimes following transarterial chemoembolizations. These biliomas tend to be very complex cystic lesions and may be located within the parenchyma or in the subcapsular location. So if you have this kind of a setup post-trauma, post-surgery, or a post-intraarterial therapy, if you see a cystic lesion multiseptated, obviously you are dealing with a bilioma. There are few metastatic lesions may present as the cystic lesions, complex cystic lesions. Sorry, एक second. Sorry.
Saliman, you want to take any question? Okay.
I think
No, perfect. Yeah.
Sorry,
so
sir.
we need to, time is a bit of an issue. We need to, can we continue more, sir? How much time do we have, sir? More?
अभी कितना बचा है सर?
15 मिनट पे कर सकते हैं, 15 minutes. 15 minutes. Till 1 minute.
Sir. I will just cover up the come to the solid lesions because that is very, very relevant. Okay.
Right.
So now coming to the solid lesions, you have to look at the whether the lesion is enhancing or not. The enhancement pattern will guide you the narrow down your differentials, whether it is a nodular, homogeneous, peripheral rim, or heterogeneous. Let us see these things. So this most common solid lesion is the hemangioma, and it will typically shows peripheral nodular enhancement and gradually centripetal filling in. And these lesions on ultrasound tend to be very, very echogenic. So especially you have done a imaging for as a screening modality or for some other purpose, you see these echogenic lesions, certainly you may not need further imaging, but in a high risk individuals like cirrhotic or in a known malignancy, if you see this kind of a echogenic lesion, you need to be evaluated by triple phase CT or a MRI. So this will show nodular enhancement, centripetal filling in, is highly suggestive of hemangioma, no need of biopsy, no further imaging is needed. Okay. So typical nodular enhancement. So there is only one differential for a peripheral nodular enhancement with centripetal filling in, that is hemangioma, nothing else. And there is what we call it as a flash hemangioma. That means it will not show nodular enhancement, it will enhance in only arterial phase and it will become iso in the rest of the phase. So that is again usually incidentally picked up. Usually on ultrasound, these lesions go undetected. On CT, these features are very, very suggestive, don't need further imaging. Giant hemangioma is a criteria where there is a large hemangioma which lacks the central filling in, you will have a fibrotic scar. So it is called as a giant hemangioma, usually more than 10 centimeter lesions. The central area remains non-filled with contrast because of hyalinization or a fibrosis. Now coming to the another common benign entity, you should not be mistaken for a HCC or any metastatic lesion, that is a focal nodular hyperplasia. So this is typically remains iso intense on T1 and T2 and shows an enhancement, homogeneous enhancement in the arterial phase, and becomes slightly iso or remains hyper to the rest of the liver. It has a central scar. If you see here, there is a central scar which tend to enhance in the delayed phase. So because of functioning hepatocytes, if you do a 1 hour image, this scar and the lesion will take up the, because of functioning hepatocytes, it will take up the contrast. And the central scar, the only pathology, only lesion which shows scar enhancement, which is nothing but the FNH. Okay. In this example, I have shown this was enhancing lesion in the arterial phase becoming iso in the portal and the delayed phase, but showing a retention in 1 hour image, that is hepatobiliary phase. It is very, very suggestive of FNH, no need of any biopsy. Don't go for any biopsy. Again, the coming to the other benign lesions in the middle-aged female who are on contraceptive, and if you see these kind of echogenic lesions, these hepatic adenomas have a variable appearance on ultrasound, maybe iso, hyperechoic or hypoechoic. It won't, ultrasound will not help to you to narrow down your differential. Obviously, if you see a solid lesion, it needs to be evaluated by triple phase CT or MRI. So how will you differentiate whether it is adenoma or something else? Again, it will enhance, but it will not show any washout. Just remember that washout is an important feature of a malignancy. Any lesion which does not show washout, you are more or less dealing with the benign entities. Just remember that. Okay. So this lesion, the typical, again, if you demonstrate the fat, in this case, there is a presence of a fat. This is in phase. In the outer phase, there is a signal drop, and it shows enhancement in the arterial phase, retention. But in the hepatobiliary phase, because it does not contain any hepatocytes, functioning hepatocyte, it will not show any uptake of the hepatocyte specific contrast agent in the 1 hour image. But these images like presence of fat, enhancement, and retention, they are typical of hepatic adenoma, but it can bleed. If you see it, these are multiple lesions showing an enhancement and washout. You may mistake it for Mara HCC. Yes, you are right. It could be HCC, but there is a presence of a bleed. There is a presence of a fat because there is a signal drop. If you see compared to these images, this is in phase and this is out phase. And there are hyperintense areas in T1 weighted image. So this lesion has got bleed as well as a fat and showing enhancement, although there is a washout. So there is a variety called beta-catenin. There are molecular classification of hepatic adenoma. The beta-catenin may show typical features just like HCC. So this is one hepatic adenoma type. We may go wrong. Only biopsy will tell you that this is adenoma, but there are subtle features like hemorrhage, fat will help to differentiate whether it is HCC or adenoma. Okay, just remember that. There are normal variations like attenuation differences, like TAD or TAD. When you discuss scans with a radiologist, sometimes we say that this is a perfusion abnormality. On typical CT and MRI, this is not ultrasound picture. This is usually a CT or MRI picture. What happens is that in the arterial phase, you will see an area wedge-shaped or ill-defined enhancing area, which persists in the portovenous phase and becomes in the iso in the delayed phase. And it is usually seen after any locoregional therapies or due to portal vein thrombosis. In order to compensate that portal circulation, the hepatic artery flow increases. So you will start seeing the wedge-shaped perfusion abnormality in the arterial phase. So whenever you see any enhancement which has got a wedge-shaped peripheral distribution and accompanied by any portal vein thrombosis, so you should make a diagnosis of the transient attenuation difference or a TAD, what we call it, a TAD or a TID. This was a question one we discussed whether this is a large regenerative. In Budd-Chiari syndrome, we get two kind of nodules. One is regenerative nodule, another is the HCC. Can we differentiate? Yes, we can differentiate. Where we don't apply Lirad in Budd-Chiari syndrome, any nodule, if it is suggestive of a HCC, it has to be proven by biopsy. We cannot apply by Lirad system for Budd-Chiari. So the earlier you used to call it as a nodular regenerative hyperplasia. Now the term is changed. We call them as a large regenerative nodule. These tend to be very, very multiple, less than 2 centimeters, scattered in both the lobes. They show enhancement. This enhancement will persist in the portovenous phase. They will not show any washout, unlike HCC. So multiplicity, small size, scattered both the lobes, persistent enhancement in the portovenous phase, typical of large regenerative nodule. Whereas these on T2 weighted image, these tend to be hypointense. On T1 weighted image, you may have hyperintensity because of iron deposition, but they will not show any washout. Whereas HCC in Budd-Chiari syndrome, the enhancement pattern remains the same, like cirrhotic, like enhancement in the arterial phase and the washout, but you have to prove it. And in the HCC in Budd-Chiari background, they tend to be single, they tend to be very large, and they are usually associated with cirrhotic changes. And these regenerative nodules may be seen after some shunt surgeries like TIPS. If you see this patient has undergone TIPS, but these nodules are seen, or even after mesocaval shunt, this patient has undergone mesoatrial shunt. If you see, these are multiple nodules. These are again benign regenerative nodules. You don't have to sample them because they are associated, they are developed as a compensatory mechanism because of some vascular occlusion. Okay. Just I will finish it up with the HCC. So in high risk individuals, if you see any lesion which shows an arterial phase enhancement, washout in the portovenous phase, this is nothing but, and showing a capsule all around it, it is typical of HCC. You don't have to sample in a high risk individual. Cirrhotic, chronic hepatitis patients, you don't have to sample them. What are the other morphological features which will help you to favor the HCC diagnosis? The extension into the portal vein or extension into the hepatic vein. So they have a propensity to vascular invasion, unlike cholangiocarcinoma. The cholangiocarcinoma, sometimes it becomes difficult in the background of cirrhosis, whether it is a cholangiocarcinoma or a HCC. But invasion into the portal system or invasion into the hepatic vein system, it favors a HCC over cholangiocarcinoma. We have three morphological patterns. One is the solitary, single lesions, multifocal, more than one lesion involving both the lobes or a single lobe. Third one is the infiltrative. It tends to be very, very ill-defined. It has a infiltrative tend to have a propensity to invade into the portal vein, what we call it as a tumor in vein. So these are the three morphological patterns. It may contain a macroscopic fat, very rare, and it may bleed inside the tumor, what we call it as an intratumoral bleed, or it may bleed outside the liver surface. It may rupture into the peritoneal cavity or a subcapsular area. So this was the exophatic lesion, has ruptured into the subcapsular area. The fibrolamellar HCC, it is usually seen in young patients. How will you differentiate classical HCC from fibrolamellar? The fibrolamellar HCC, where serum alpha fetoprotein is normal, and you tend to have a calcification in the center, or a scar which is found will have a calcification in the center. One other common entity you can encounter in the cirrhotic background is the intrahepatic cholangiocarcinoma. How will you make a diagnosis? You will have a peripheral rim enhancement. Unlike HCC, HCC will not have a rim enhancement. It will be a homogeneous, whereas cholangiocarcinoma tend to have a peripheral rim enhancement and a capsular retraction as you take photovenous and delayed phase, you will see a washout from the periphery and a filling in the center. Why it fills in the center? Because it has got a fibrous serous stroma in the center, and the peripheral enhancing area will starts getting washed off. So in the arterial phase, peripheral rim enhancement, capsular retraction. In the photovenous phase, peripheral washout and central filling. Unlike hemangioma, it will start filling homogeneously, but in cholangiocarcinoma, peripheral washout and central filling in. And sometime, if you see, this is a multifocal cholangiocarcinoma showing a peripheral rim enhancement, and in the delayed phase, there is a central filling in and but a peripheral washout. You may have a morphology containing both HCC as well as cholangio. What we call it as a mixed hepatocholangiocarcinoma. If you see here, this lesion has got peripheral rim one area and homogeneous enhancing other area. When you do a photovenous phase, the homogeneous enhancing area will show washout. The peripheral rim enhancing area will start showing filling in. So this is very typical of a mixed variety of hepatocholangiocarcinoma. So I think because of time, I will not be able to cover. So if you have a question, we can have a discussion.
I think you covered up really well, showing us how the various imaging phases, like how do we see on the phases, the various lesions. I think we've got a couple of questions, and it would be good if we can have more questions in the chat box.
Yeah,
so that
rather than here.
we can,
Yeah.
So Pradeep wants to know, is there any cutoff for defining giant hemangioma?
Yeah, giant hemangioma criteria is more than 10 centimeter, but it has to have a central scar, like fibrous hyaline because of. So usually cutoff point, we take it as more than 10 centimeter.
Right. So Suma wants to know, and I think we've got a similar question from a couple of other uh, residents also. Wants to know, how do we differentiate dysplastic from a regenerative nodule?
Yeah, the dysplastic nodules, we have two types of dysplastic nodule. One is low grade, another is high grade. The regenerative nodule will most of the time they remain hypo or iso to the liver parenchyma. Usually these are pathological diagnosis, but at all we see a nodule which is iso or less than hypo to the rest of the liver, we call them as a regenerative. Whereas the dysplastic nodules on T1 weighted, all these regenerative, low grade or early HCC, where they are better appreciated on MR. It's not a CT characterization. So low grade tend to have hyper intense on T1, hypo intense on T2, do not show enhancement. Whereas high grade dysplastic nodule, they will show enhancement in the arterial phase, no washout. So that is the difference. The signal properties of low grade and high grade, T1 hyper, T2 hypo, only way differentiating low grade from high grade is the enhancement. If it enhances, does not show washout, it's a high grade. The high grade, if it shows a washout, again it becomes HCC. So that is how you differentiate. The regenerative nodule will never enhance.
Right. So we've got two similar questions. One from Prashant wants to know is the response to pace, how is it assessed? And similar is on the lines as when we use the M-resist criteria.
Yeah, that because of time I did not cover. So any loco-regional therapy, systemic therapy or immunotherapy has to be evaluated by modified RECIST criteria. It mainly depends upon the measurement of the viable tumor in the arterial phase. So in the arterial phase, you will look at whether the tumor has got an enhancing component or not. We never measure the overall size shrinkage. We only measure the viable tumor. The viable tumor is measured on the arterial phase. That is one. So the criteria is modified RECIST criteria based upon the viable tumor. Second is at what point of time you are going to image. It is at 4 to 6 weeks, the initial imaging, whether it is stays ablation or the sorafenib or immunotherapy. It is at 4 to 6 weeks initial therapy. However, if you are subjecting that patient for tear or a SBRT, the first imaging has to be done at 3 months, not at 4 to 6 weeks. Because the SBRT or a tear, the response takes little bit longer time. If you do a imaging at early, you have a flare response, you may appreciate that tumor has increased in size. So that's why if you want to evaluate the patient after SBRT or tear, you do imaging at 3 months, but the rest of the cases at 4 to 6 weeks. And if you are doing conventional tests, go for a MRI. In rest of the situation, the CT and MRI equally good. In conventional tests, we advocate use of MRI because the lipidol what we inject in conventional tests, it hampers the whether the tumor viable tumor or is it a lipidol. So that we tend to make a mistake. So that's why if your patient has undergone conventional tests, go for MRI for response evaluation at 4 to 6 weeks. And the follow-up imaging has to be done after initial imaging is every 3 months for the first year. So
Can you
I
stop
hope.
sharing your screen?
Okay.
If you stop sharing your screen. Yeah.
Okay. Okay.
We've got
So I
another
hope.
question from, yeah, I think that's very clear, sir. The next question is from Dr. Munish, who wants to know, which I think you've already told us, he wants to know the name of the dye which can be used safely in patients with kidney disease who are undergoing a CT. I think you talked about MR. CT
MRI.
is something,
CT,
yeah,
no.
which, right. So MR can be done. We've got renal safe contrast, but not on CT. CT will have issues. Okay. What we have a next question is, what is the role of biopsy? When do you subject a patient with a liver lesion for biopsy? Like what imaging findings make you think that you're not sure? And then you would say that, okay, from your perspective, the patient needs to undergo a biopsy.
So in this setup, you have to look at whether patient is a high risk individual for HCC or not. Obviously, he must be talking about non-cirrhotic patient. Any solid lesions, even if it is typical of HCC, other than hemangioma, FNH, perfusion abnormality, or a simple cyst, you need to have a biopsy. But always take into confidence of the surgeon, because sometimes the surgeons are keen to go for solid lesion. If they feel that it has to be out, go for a resection rather than wasting time in that. But there are typical imaging features like FNH, hemangioma, perfusion abnormalities. I have shown some of the other list. So you don't need any imaging. Okay. You don't need any sampling like focal patty sparing, focal patty infiltration. You can clearly demarcate them. But all the solid lesions other than these what I have mentioned need to have a biopsy. And also HCC or cholangiocarcinomas, the HCC in cirrhotic, no need. Cholangiocarcinoma, again, need a biopsy. In non-cirrhotic, whether it is HCC or a cholangiocarcinoma, you need to sample them.
Right. So, good. So we've got a question from Sudhir, who wants to know is the characteristics of hemangioendothelioma on imaging, like a CT or an MR.
Yeah, this is, although it is a very, very rare entity, what we get is the multiple, usually seen in a young female or middle-aged female, multiple peripherally located lesions. They tend to cause capsular retraction and may show a peripheral rim. Unlike hemangioma, these do not show nodular enhancement. These maybe only show a peripheral rim enhancement. These are solid lesions, tend to be multiple, peripherally located, may have a calcification, and tend to cause capsular retraction. So this is a typical appearance of a hemangioendothelioma.
Right. So Prashant has a question. He wants to know, like I think we've already talked about also, is like when you're assessing response post days or say SBRT, is the assessment criteria same? And
Yeah. Response criteria remains the same. We classify them into partial response, stable disease, progressive disease, or a complete response. And the criteria we use is the modified RECIST.
Correct. We've got a question from Dr. Rakesh who wants to know. So, if you have imaging which has already shown you a dysplastic nodule, what further imaging or at what interval would you suggest that these patients need to be followed up?
See, currently in high risk individuals, we apply a LIRAD system. So this plastic nodule, if it is showing enhancement, it's like high grade dysplastic nodule, it falls in LIRAD 3. So we need to further imaging done at 3 to 6 months. Okay. So in order to demonstrate washout or interval growth. So if it shows a threshold growth of more than 50% in the further imaging at 3 months or 6 months, so even though it does not show washout, we characterize it as a HCC 1. Or if it shows washout or a capsule, again, we upgrade it to LR4 or LR5 depending upon the size. So obviously LR3 lesions need a follow-up imaging at 3 to 6 months, whereas LR4, it has to be discussed in the multidisciplinary meet, whether we can go for a biopsy or do a follow-up imaging.
Right. We've got one question from Dr. Kondal. He wants to know any imaging characteristics of a lesion which could be tubercular, something like a tubercular SOL or an abscess. How do we think about such lesions?
See, tubercular abscess, single abscess, very difficult. But if you have multiple hypodense lesions scattered entire liver involving spleen and necrotic node, then only we can make a diagnosis of TB, but it has to be sampled. There are no specific imaging features that we can say that it is TB only. No, it could be fungal, it could be TB, or it could be sarcoidosis also. We have to differentiate it.
I think I'm done with most of the questions. Some questions deliberately, which are probably very relevant to the surgeon or to something else, I've not taken. But I think I have tried to take up all questions. One question I would like to ask from my side, and for I think which is very relevant to everyone, is what would be the role of PET scan? I think it's though it's done in the nuclear medicine department, but
Yeah,
I think that
actually,
also plays a good role in assessing the liver lesion. So, what are your thoughts on that?
actually, even in, especially if the patient is having high, especially in what I encounter is the HCC cases. So if the patient is having a high AFP level more than 400, you have to rule out some extrahepatic component 1. Or in another setup is if the patient has shown a complete response, but AF is it is increasing in trend in the follow-up visits, then you need to look at any extrahepatic disease, not for the local response. So, or mainly it is mainly advocated in the case of HCC to look for the extrahepatic disease rather than a local response assessment. But if the patient is planning for a tear and other thing, the PET is always done. That is a different scenario, different discussion altogether. But coming to your question, mainly in response evaluation or after the local regional therapies, mainly to look at the extrahepatic disease rather than a local disease.
I think that would be the real role, actually, more on extrahepatic, not in the hepatic, because we've got good modalities like MR and CT, in which we've already looked at the liver much better than what the PET can give us an idea what's happening in the liver, but extrahepatic definitely.
Yeah, if you have access to that and you are have a collaboration with the PET people, always tell them to do a triple phase CT and the PET, so that you can save a time, so that those data can be used for the interpretation of the local disease as well as the extrahepatic disease, rather than subjecting patient twice.
Right. So I think this was the last question from my side. It was real good interaction, seeing all the excellent cases, how you made such complex radiology so simple for us clinicians to understand, because we find it many a times very difficult to understand what is this different types of phases, what contrast to use, what modalities to use. I think you've given us a very simple way forward how we can understand what each of these modalities have for us to offer in terms of evaluating and managing and following up our patients. So with this, I'd like to hand it over to Professor Bhattaria sir to move to take it forward.
I think very well said, Salimar. Very well said that what Siva did is fantastic. Thank you, Siva, so very much to making
Thank you.
radiology, understanding of liver lesion simpler for a clinician like us.
It's a big topic. Many topics are left, but ठीक है, मतलब, only we can give an overview because liver itself is such a big topic. You can talk each topic in a long discussion actually.
Absolutely. This is exactly what Prashant also says. Prashant's right that we can have a second part of it some more time, so whatever left out in this lecture. So I think this has been a fantastic coverage of understanding liver imaging, starting from that how liver, we look at liver in ultrasound, CT scan, and MRI, what to choose and when to choose. And more importantly, at the same time, I always had difficulty understanding segment of liver. And after multiple classes by you guys, you and Dr. Raju and everybody else, it's difficult to understand and keep a picture in mind how to different these lesions or these segments on imaging. But you made it very clear. Your diagrams and were very, very nicely depicted. But I still request everyone that please revisit this lecture, which is recorded already and will be put on ISG website. So please visit again. It's been difficult for all of us, and it is for me, it has been difficult to understand all the segments of liver in one go. It's about practice. It's about going, listening to that or reading that part time and again, making in mind the concepts that the one horizontal line, the three vertical lines, which Dr. Siva showed so well by his pictures, and then what are segments for liver, which are anterior, which are posterior, and once you see the CT imaging, where to look at. Initial imaging superior, then inferior, which segment will come on top of the CT scan film, which will come on below the CT scan film, lower part of the CT scan film. It's a matter of practice, and it's good to do practice. And you might like to listen to this lecture again to understand those concepts. Second one was, I just want to tell what Dr. Sivas and Dr. Salimar said, that if ever you find a lesion on ultrasound, a SOL, and you want to characterize it, we have seen that many people do a CT scan or CECT, but that's not right. The first test you might like to do a multiphagic CT scan rather than doing a first step CT scan and then multiphagic CT scan. To characterize a lesion in the SOL in the liver, the best way to do a multiphagic CT or MR. Am I right, Dr. Siva?
Yes, sir.
So I think you should change practice. Somebody is doing CT scan, probably go towards a multiphagic CT scan. I think
not for simple cyst. Not for simple cyst.
Absolutely. I said solid reasons. Simple cyst, you don't need to do a dual phase CT scan. I think with this, we are up to the time, probably about 3 minutes more. So we need to close this session. And I'd like to thank on behalf of Inner Gastroenterology, both Dr. Siva for a wonderful presentation and Dr. Salimar for moderating the session so well. Thank you so very much on behalf of ISG and all of us. Listening here. It has been really wonderful experience. Thank you everyone for joining in the masterclass. And we really get encouraged once you join and listen to the good lectures by some of our best experts in our country.
Thank you.
Let me also invite you to the next masterclass that will be on imaging of small intestine and large intestine. And again, we know that which test to do, which imaging to choose, how to interpret, what are the limitations of interpretation of these imaging. And for that, we have again, wonderful speaker, Dr. Raju Sharma. I would say he's one of our best teachers in GI radiology. And we know his qualities. So we wish to listen to him on 14th of August, 2022. That's after one Sunday. Next Sunday will be in Nazil. So after that, we will have on 14th of August, a lecture on small and large intestine. With this, thank you so very much. And also, I want to remind on behalf of ISG that the abstract for ISG Con 2022 is going to close on August 15. And Nisa reminds me that please ask all of you and your colleagues to submit abstract for ISG 2022. And the portals are all open, so please do submit your abstract. With this, thank you, Dr. Shivanand, Dr. Salimar, and all our tech team, all of you. Nisa, thank you for organizing this. Thank you, Dinesh, and your team for organizing and webcasting this masterclass. With that, have a great day and bye-bye.
Thank you, sir. Thank you, everyone. Thank you.